Assalamu alaikum. Good afternoon, everybody. I hope everybody is enjoying the Congress. I'm Yusuf Saleh. I'm the immediate past president for GAED, Gulf Association of Endocrinology and Diabetes. It gives me great pleasure to welcome you all to the GAED middle presentation for the year 2021. And this prestigious presentation has been given this year to a very distinguished speaker from the United States, and I'm really pleased and honored to present Professor Bess Dawson-Hughes. Professor Dawson-Hughes graduated from Tufts University School of Medicine, where she completed her house training at the same university, and then subsequently she finished her fellowship training in endocrinology at Harvard Medical School. She is a very distinguished, well-known authority in the world in the field of bone and mineral metabolism. She has more than 425 peer-reviewed journal articles, book chapters, and reviews. And she received many awards for her research and scientific leadership, including the International Osteoporosis Foundation President Medal and the IOF Award for Scientific Achievement. She is currently the General Secretary of the International Osteoporosis Foundation, and she is the past president of the National Osteoporosis Foundation. She is the founding director of the Center of Advancement of Science and Space, and this is a board which directs research and technology development on International Space Station National Laboratory. Her interest is mainly calcium, vitamin D, protein, and the acid-base balance of the diet, influencing age-related bone and muscle losses. She is one of the most highly cited researchers and one of the top 1% in her field. And we are really pleased and honored and engaged to listen to her presenting on year in vitamin D. Professor Bess Dawson-Hughes.
Hello, greetings from Boston. It's a pleasure to be with you today to address the year in vitamin D, and it has been quite a year. I will be showing you my disclosures here, and then moving on to the objectives of the presentation. We will discuss the impact of vitamin D on muscle performance, on risk of falls, what have the recent mega trials added, and we'll explore the possibility of a alternative pathway by which vitamin D may influence falls, and wind up with a very brief rundown of some of the other important outcomes in these mega vitamin D trials. So, we know that there are age-related changes that occur in muscle. We lose our muscle fiber number that goes down, and we lose it disproportionately in the type 2 fiber category. These are the fast twitch fibers that affect our ability to catch ourselves were we to start to fall. And moreover, we lose stem cells for the type 2, these so-called satellite cells, which fits together with the fact that we have fewer of these cells. So what does vitamin D have to do with this, if anything? Well, interestingly, Ferrari some years ago looked at the vitamin D receptor number in human muscle biopsy specimens, and saw that as a function of age, there were fewer and fewer of the vitamin D receptors, suggesting a role for vitamin D here. We've had, over the years, many studies and meta-analyses looking at the effect of vitamin supplementation on muscle strength. In this example, a very fine meta-analysis by Charlotte Bodar. Interestingly, the study that was very influential in the conclusion that vitamin D supplementation improves strength was the study by Sato, which has since been retracted. Without that study, it's questionable whether this meta-analysis would have shown an association of supplementation with improved muscle strength. We also have the older study that's a classic, often cited study of the same vintage, roughly, by Michael Pfeiffer, showing that body sway was greater in deficient individuals, and that treatment with supplementation would lessen the sway. And sway is a predictor of falls. It's a balance test, obviously. So this brings me to what's new this year in the area of vitamin D and muscle performance. And it was just published, it's out online in JBMR by Bislev and colleagues, very fine investigators, looked at 54 randomized controlled trials, and these trials, some of them used daily, some bolus dosing, some were months in duration, others years, some with calcium, others without it. And they looked at a bunch of these muscle performance tests that were published in the individual trials. So I'm going to take you through the results of these tests rather quickly, because they all will drive home the same point. Here's the time up and go. Impact, not significant. Supplementation, no impact. Knee flexion, commonly measured. Similarly, no significant impact. The SPPB, the short performance, physical performance battery, used in elders, and it was null. The trial level vitamin D and the chair rise tests, often done in a number of these trials, null. Overall, the 6-minute walk, which is an endurance, not a type 2 fiber sort of test, and it was null as well. Now, Bislev concluded that the statement, the commonly made statement that vitamin D protects muscle health, lacks clinical evidence, and adverse events may even be present. She also commented that despite enormous efforts in randomized trials, we have only good evidence that D combined with calcium plays a role in the prevention and treatment of osteoporosis. In other words, fracture prevention. An invited commentary to this very recent publication by Roger Bouillon and Dan Bickley, they agreed with these conclusions. So now let's move on to what the recent mega trials have added to the picture of whether vitamin D affects fall risk. Here's one you're familiar with, I'm sure, the VITAL study in over 25,000 older adults. They were not selected on the basis of their fall risk. They were replete in vitamin D at baseline, shown as here in orange, the 30.8 nanograms going to 41.6 on treatment with 2,000 units of D per day. So that increment did not influence fall risk at all in these participants, as you can see in the graph. There's been another rather complex study. It's with a so-called adaptive design, the STURDY study by Larry Appel, who's a fine investigator. They tested they had 4 arms in the original randomization. The plan was to treat with the control dose of 200, 1,000, 2,000, or 4,000 units a day in a randomized manner for 2 years, and then to pick the most promising dose at that point to go forward for 2 additional years to see if they could get a sustained or a benefit of that. And you see, we will look first at the adaptive phase, and the result is shown here. It turns out you see the 200 unit doses in the dashed line. 2,000 units actually significantly increased falls in that 2-year adaptive period. The 4,000 unit dose was similar to the 200, and the promising looking dose was 1,000 units a day. So what the investigators did was to transition those individuals in the 2,000 and 4,000 unit groups to 1,000 units a day. They kept the 200 unit group intact, but added more people to it, recruited some new people for the 200, and they carried on for 2 additional years, comparing in a larger sample size the 200 versus 1,000 units. And here's the result of that confirmatory phase. You see the 200 and the 1,000 unit doses had the same amount of falling. In other words, the hazard ratio, while it was 0.94, the confidence intervals were wide and widely straddled 1. So they could not demonstrate effect. I should point out that this population was recruited because of their recent fall history. They were all over 70 years of age, and so they were a very high risk for falls population. Then we have just published a few weeks ago the long-awaited DHealth Australia study. 21,000 adults aged 60 to 84, selected out of the general population of elders, were randomized to 60,000 units of D3 per month versus placebo and followed for 4.3 years. This was a rather pragmatic trial. They didn't have visits and so forth. It's rather like the VITAL study. And in 16,000 of the participants, they were randomly selected for an annual survey of falls by a mail-out questionnaire. The study did not have visits, didn't have blood draws in everyone, but they did look at the intra-trial 25-hydroxy-D level in a small subset, but adequate, of 450 per group, and found that the placebo was at 31 nanograms. That's almost identical to the starting line of the VITAL study, and it's certainly in the replete category. And the 25-hydroxy-D level reached on supplementation 46 nanograms per mil. So here is the results. The upper red rectangle shows the main results in all 16,000 people, and it was not significant, with an odds ratio of 1.02. Down below in the rectangle, you see body mass index. It turns out that the subset of people with a BMI less than 25 kilograms per meter square had more falls than those higher weight, higher BMI participants. There was also a hint that that the low D people would benefit from supplementation in the lower part of that rectangle, but it was not significant. So another null trial in people who were adequate at baseline. That result is quite similar. You know, the Australia D used 60,000 a month. That takes us back to the old Ferrari study of 2016, testing that same dose in group B compared with 24,000 units a month, which would translate roughly to 800 units per day. And she saw more falls in that 60,000 unit dose. However, her individuals, their average BMI was 26, so about half of them approximately were under 25, presumably, and these were people at high risk for falling, selected because they had had a fall in the last year. So the 60,000 units, it does not look safe in high risk for fall elders. It may be okay in those who are not that size or at that level of risk, but we I wouldn't bet on it. In the Ferrari trial, the 25-hydroxy-D levels were at baseline in the high teens nanograms per mil. The 800 unit equivalent dose in the lightest bars brought the levels up to about 38 or so nanograms per mil. And so we're looking at more falls at 38 than there were at 21 nanograms per mil. And of course, even higher levels were achieved in that third group. So there's one other classical fall study to try to relate these new trials to. This was done by Smith and Gallagher. It's smaller, but it was carefully assessed falls. 146 Caucasian and 91 African American women, and their recruitment eligibility or enrollment eligibility required that they be insufficient under 20 nanograms per mil. So they used multiple doses, but I'd like to focus your attention on the right-hand panel of the slide where we are looking at 25-hydroxy-D levels achieved on treatment and proportion of fallers. And you could see that in the dose range, in the 25-hydroxy-D range of 32 to 38 by one assay or 35 to 41 by the other, there were the lowest number of falls, and there were significantly more falls as 25-hydroxy-D levels rose above around 40, 41 nanograms per mil. So here's a summary of this confusing picture. We're trying to get at a couple things here. One is there a range of 25D that we should stay within to minimize falls? Or is the problem that we're using intermittent bolus doses versus daily doses? And it's really, I think I can't quite sort this out from what we have here, but here's a try. So the fall risk level increasing is represented by the yeses in the far right-hand column. The new studies are in orange. The classics we just looked at are in white. And you can see that you get more falls in high-risk elders in the Appel study at 2,000 and 4,000 units. DHealth, in a normal average risk population, you get more falls if your BMI is less than 25 on that dose, shown 60,000 per month. Ferrari saw that that you got it in more falls in everyone if you're at high risk for falling and older, with 60,000 a month. And Gallagher, as we've just reported, showed that levels above 41 are suspicious for more falls. So my takeaway is that you don't want older adults, whether they're at high risk for falls or not, exceeding a 25-hydroxy-D level of about 40. And you don't want them in the insufficient and deficient range either. So until we get a better handle on this, I would say the safe territory is the 20 to 40 nanogram per mil range as a treatment goal. That's just my opinion. It's not a guideline. We know from earlier trials that de-dosing in the lower dose ranges in response and showing risk of falls is summarized here in a 2009 meta-analysis. And it looks from this just visually as if you're in the 700 to 1,000 unit range, you're benefiting, and if you're lower doses than that, you're not. At that time, there were no high dose trials to complete the picture on the right. Let's move now. I'm going to briefly address something that's been intriguing to me recently, and that is the possibility of a different pathway. We have looked at this classic pathway shown on the right, and we're not seeing the benefits of treatment with D on muscle outcomes and not consistently on falls. We do adhere to the left-hand axis, which fits with available evidence beautifully, that you get decreased absorption, increased PTH, turnover, and fractures. I'm wondering whether PTH elevation in response to D insufficiency may be have a direct effect on muscle strength and therefore on falls. So let's look at a little bit of evidence to support this maybe wild hypothesis. And that is that in rats, stimulation with the intact PTH or the active 1 to 34 amino acid fragment increases muscle proteolysis in rats, and they've shown this proved it in several different ways. But so there is a rat precedent for this. There's also a paper, the senior author was Gerald Auerbach, the famous endocrinologist. This was in the mid-1970s. They had reported muscle findings in 16 patients with primary hyperparathyroidism. And these included, out of the 16, there were 13 that felt they had no stamina, 12 generalized muscle weakness, poor tests with proximal muscles, aching muscles, unsteady gait, and so forth. A subsequent study by a British surgeon looked at some actual knee extension measurements in patients with primary hyperpara before and then 7 months after successful parathyroid surgery. And there was a 8% improvement in their muscle strength at 7 months later. And the degree of change or improvement was correlated with the circulating calcium concentration prior to surgery. In other words, those with more severe hyperpara had a more robust recovery than those with milder, suggesting a direct effect. Then Bislev, earlier in 2019, did a cross-sectional study in 104 healthy older women, all of whom had low 25-hydroxy-D levels. She divided them into two equal groups. Well, they turned out to be equal. She divided them according to whether the circulating parathyroid hormone level was above normal or within the normal range. So in the picture here, you see the clinical characteristics of the two groups, the secondary hyperpara shown first, and then the normal PTH levels. And importantly, the 25-hydroxy-D level in the two groups was similar. So we're not looking at different degrees of D insufficiency. They were all insufficient, but equally so in the two groups. And of course, the parathyroid hormone levels were higher because that's how they were selected. Now let's look at what she measures then, and that is knee flexion, strength, and maximum force production at 90 and 60 degrees. And in these measures, those with secondary hyperpara, the higher PTH group, had poorer performance, as indicated by the bolded p-values in the final column there. So there was a muscle performance difference. And there was also more sway in the semi-tandem stance shown on the left in the higher PTH groups. So there was probably an effect on balance and as well as on muscle strength. And last, a lovely study by Phil Sambrook, who was doing an observational study in over 600 ambulatory elders in intermediate care hostels and nursing homes in Australia. And he was assessing falls And the setting is relevant here because staff in these institutions were actually documenting falls. We were not dependent upon men and women in their mid and late 80s to remember whether they'd had a fall or two falls or what. And so high quality, 73% had D level, 25 D levels below 15.6 nanograms per mil. So it was a D deficient group, right for assessing the question here. And 274 of the elders, over a third of them, fell over this 10-month intervention or observation period. Here are his findings from a multivariate analysis. He looked at the association of 25-hydroxy-D with falls, and after adjusting for PTH, it was not significant. Similarly, he looked at PTH, and after adjusting for 25-hydroxy-D, which of course was similar in the two groups, found that it was the predictor, not 25-hydroxy-D. The model was also adjusted for other comorbidities and balance and so forth. So this is our strongest signal, actually, that PTH may be driving the bus here for falls, since we are finding that 25-hydroxy-D isn't making that much difference. This needs confirmation. It is unclear at this point whether this is real or not. So I want to now at the end give you just a few highlights of the primary endpoints of these mega trials that have been published recently. These are not musculoskeletal endpoints, but they're nonetheless important in relation to chronic diseases. Here's the vital study cancer outcome. You know the story of the over 25,000 people. The hazard ratio for incident cancer was 0.96 with a wide confidence interval. After taking out those who developed the cancers in year 1 or year 2 of this 5-year study, it was similarly null. There was a flicker of hope for the vitamin D intervention, and that was that cancer deaths, a secondary endpoint, were reduced with the vitamin D supplementation of 2,000 units a day. What about cardiovascular disease? That was the co-primary along with cancer in the vital study, going down on the left-hand column to the hazard ratio of 0.97, wide confidence interval overall, no impact on cardiovascular disease, and similarly no impact for those small subset who had insufficient D levels at entry into the vital study. Similarly, on the right-hand panel, we have the VITA study from New Zealand, hazard ratio 1.02 for cardiovascular disease or mortality, cardiovascular mortality, and 1.0 for those with an initial low D. So all the observation studies suggesting that higher D was protective were basically looking at people who not only were taking care of their vitamin D status, but other health needs at the same time that were not adjusted for. The DHealth study out of Switzerland involving 5 countries in Europe, testing 2,000 units a day, similar intervention to the vital study. The people had a 22.4 nanogram starting level of 25-hydroxy-D. Look at the SPPB scores, 12 out of a possible of 12. I think they recruited a bunch of Swiss mountain climbers. These people were very fit elders. And the vitamin D outcomes, there were 6 primary outcomes, and none of vitamin D had no significant effect, had a significant effect on none of these outcomes. So disappointingly null. I'm going to wrap up with the looking at another outcome, which is type 2 diabetes. The D2D trial, which I have been heavily involved in, was testing 4,000 units per day of D3 versus placebo on conversion to diabetes based on American Diabetes Association criteria in a bunch of recruits who were classified as pre-diabetes, so high risk for conversion, people over 2,400 of them. And we found that vitamin D lowered risk by 12%, but it was not statistically significant. This result is very similar to that of the European study by Gorda, showing the same kind of range of decrease. Well, that's not nothing if it's true, but we can't tell. We wondered in looking at this whether the people who achieved a higher 25-hydroxy-D level may have benefited more than those who did not. And so we looked at this question in the D2D cohort. In the upper panel, we show the participants who had been assigned to the 4,000 units of D. We sorted them by the category of intra-trial mean levels of 25-hydroxy-D. We had measured it 0, 1 year, and 2 years. Took the mean in the trial and looked at outcomes having adjusted for age and sex and the usual cast of players. And you'll see highlighted in yellow there that those individuals treated with D who achieved a level of 100 to 124 nanograms per mil, that would be 40 plus nanograms per mil, these are nanomoles, sorry, and had a decreased risk of developing diabetes, 0.48. And if they got even higher, greater than 125 nanomoles, their risk dropped down to 0.29. And we adjusted again for any change in weight during the trial, and it didn't alter the result. If anything, made it a little better. The same trend is seen in the placebo group shown in the lower panel here. We had only 22 people in that group who achieved the high levels, so it was really hard to tell. But the same general flavor is present in the placebo group. So we are wondering and want to try to demonstrate that treating to a target level for diabetes to prevent diabetes in high-risk people may be beneficial. Of course, we'll have to demonstrate too whether it's safe, having looked at the falls data that we just reviewed. So this observation in D2D is consistent with the diabetes prevention program observation that the hazard ratio conversion in this observational study and in addition to the diet modification, the higher the D level shown on the x-axis, the lower the hazard ratio, even out at levels in the range in which we saw decreased conversion. So it's plausible. It fits with this other and other amounts of data, and it requires further investigation. I'd like to conclude with comments that supplementation of replete older adults, as we've seen in the recent mega trials, does not improve muscle performance or reduce fall risk. Supplementation to a level greater than 40 or equal to 40 nanograms appears to increase risk of falling in frail older adults and possibly in the general older population, although that is less firm. A low daily dose of 700 to 1,000 units together with adequate calcium intake reduces risk of falls and fractures in deficient older adults. An elevated PTH level may increase risk of falling independent of vitamin D, but more evidence is needed to confirm that. Vitamin D supplementation in replete adults not only doesn't improve musculoskeletal outcomes, it doesn't improve any others either, as far as we can see at this point. So the take home is the optimum 25D level to minimize diabetes risk may need to be higher than 40. But as I said, this requires verification and also assurance that treating to higher levels is safe in terms of risk of falling and other outcomes. So thank you very much for your attention.
We do thank Professor Bess Dawson-Hughes for a wonderful talk that covers many of the advancement in knowledge regarding vitamin D that happened over the last year and many new studies that has been shown by her. We do not have the luxury of time to have questions. Middle presentation usually are finished without question. On the behalf of the Board of Directors of the Gulf Association of Endocrinology and Diabetes, I would like to present this middle presentation certificate to Professor Bess Dawson-Hughes and thank her for sharing her expertise with us in this Congress. I do thank the 515 people who are with us attending this presentation, 519 now, and wish you a fruitful presentation and knowledge and academic achievement in the subsequent presentations of this Congress. Thank you very much.